Hello, everyone. We'd like to thank you for joining us today as the Allen Temple Baptist Church Health Education Ministry presents a special discussion on COVID-19 with Dr. John Swartzberg. I want to give a special thanks to Dr. McLean, Alvin McLean, his personal friend, who was very instrumental in assisting us to get Dr. Swartzberg to come speak with us. Let us pray. Father God, we just ask you to come into this call. Help us become more knowledgeable about the things we need to know regarding COVID-19. Give us the strength in order to persevere during these troubling times. We pray, Father God, that we leave here today with more knowledge and more information that would help us manage this horrible disease. These and other blessings we ask in your name. Amen. Now we will hear from the leader of our flock, the Dr. Reverend Jacqueline Thompson. Thank you.
Good morning, everyone. I pray that you all are well today. Thank you so much for joining us. I'm coming to you live from the church office. We are always at work, and we certainly want to extend our congratulations to our health education ministry, commend all of your leadership, your entire team for adapting. The one thing that the COVID-19 disease has done is forced all of us to pivot and change in ways that we have not been accustomed to. But this is an incredible format for us to get the important information that we need to make sure that we are protecting ourselves. So again, I thank you, Dr. Swartzberg, who is an expert. You have seen him featured on news channels across the nation. And we are so blessed to have him today. We see the death toll. We are hearing so many things from so many different places, but this is our opportunity to make sure we're getting the facts, that we're getting the science, so that we can make decisions that preserve our health. So I pray that it is a wonderful discussion. Please utilize all the tools available. Put your questions in the chat so that you'll be able to be engaged. And moreover, take this information and share it with someone else. Have a blessed session.
Thank you very much, Pastor, for those wonderful words. At this particular time, I'd like to introduce the moderator for today's program, Sister Ricka White-Soso. Ricka is an LCSW medical social worker, and she has a master's degree from San Francisco State University, and she's very passionate about helping others. I've worked collaboratively with her on a number of projects, and I'm just blessed to have her. Ricka?
Good morning, good morning, good morning. Happy Saturday. We want to thank all of you for taking the time out on this beautiful day to discuss a very important virtual health conversation regarding COVID-19, which is affecting us all. Before we get started and hear from our very prestigious provider and person who's going to present for us, there's a few things I'd like to do. Something we do during face-to-face. We have a little housekeeping that we do. And so there's a couple of things we'd like to make sure you're aware of before we begin. There's a Q&A after the presentation. So we want you to hold your question until after the presentation, because some of your questions may actually be answered. And so if you have any questions you find that are not answered in the presentation, feel free to put them in the chat. Also, there are 2 brief Allen Temple Health Education Ministry surveys we'd like you to complete by 6 p.m. this evening. So hopefully you'll get those soon, and if you don't have them already. So for all of you who can complete those brief surveys, there's one that's seeking input for our future planning for next year. And then there's another one that is evaluating today's program. If you complete that today by 6 o'clock p.m. and email it to healthed, HEALTHED at allen-temple.org, you will be entered into a drawing, and you have the opportunity to win one of 4 $50 gift cards. So please get those evaluations done, and you'll be reminded at the end of the seminar as well. I have the distinct honor of introducing Dr. John Swartzberg. Dr. John Swartzberg is a doctor. He's a clinical professor emeritus at UC Berkeley School of Public Health. He chairs the editorial board of the School of Public Health, Health and Wellness Publications. He served as director of the UC Berkeley, UCSF Joint Medical Program and continues to teach at that program. For 2 years, he was the president of UC Berkeley's Emeriti Association. He also is a member of the Board of Regents at Samuel Merritt University. He is board certified in internal medicine and infectious diseases. Before joining UC Berkeley's faculty part-time since 1980 and full-time since 2001, he spent 30 years in clinical practice. He also is a hospital epidemiologist and chair of the Infection Control Committee at Alta Bates Medical Center in Berkeley. Dr. Swartzberg has collaborated with the late Sheldon Morgan, a pioneer in nutritional sciences and co-founder of the Wellness Letter, on the highly successful Well Self-Care Handbook in 1998 and the Complete Home Wellness Handbook in 2001. Some of his most recent publications are the Wellness Report, Controlling Your Cholesterol, Women's Health Report, and Men's Health Report. His consultations so far this year includes Bay Area Rapid Transit, McKesson Corporation, Copper Vision, Ford Motor Company, PAC-12 or PAC-12, and Maxim Integrated. With all of that, we are so blessed to have him with us. Let's welcome Dr. John Swartzberg.
Thank you very much. And I want to thank Deacon Goodman for inviting me, and of course to my really good friend, Dr. Alvin McLean. I also have another friend in the audience, I think, and that's Anytime. So I want to say hello to you too. And I want to really thank you so much for asking me back. I had the honor of speaking with you on June 6th, and so I'm delighted to be able to speak with you again. I had a little trouble with sharing my screen, and so I sent my slides to Deacon Goodman, and hopefully he can share his screen. And while he's perhaps playing with that, I will begin my discussion. And for those slides that I aren't able to show you, I will certainly be happy to have the deacon send those to any of you who want them. And I thought I'd talk maybe for about 30 minutes and save the bulk of our time for questions. So feel free to ask anything you want about SARS-CoV-2, the virus that causes COVID. So I'd like to begin by giving us an update from our last talk on June 6th. And I think that should begin with a discussion about where we are with this pandemic. Worldwide, we're close to 40 million reported cases. We think that the number of reported cases are probably about 20% less than the actual number of cases, but the number of reported cases now are at 40 million, and the number of deaths are a little over 1 million worldwide. Nationally, we're at about 8 million cases, and we've had about 220,000 deaths. If we look at California, we're at just under 900,000 cases reported. Again, that's far less than the actual number. And the number of deaths are about 17,000. And if we look at California, it's not uniform how the number of cases and deaths have distributed themselves. The Bay Area has actually done much better than the rest of the state, or much of the rest of the state, certainly much better than Southern California, which has had the bulk of our cases percentage-wise. Right now, we're at a percentage positive, meaning the percent of people who get a test are positive at a low in the Bay Area that we haven't seen really since the end of the really draconian lockdown that we had in March and part of April. The striking numbers, though, that I think are most important for you to take away are the following. The United States has about 4% of the world's population. We have 20% of the world's cases and 22% of the world's deaths. I want to really emphasize that 4% of the world's population, yet we have 20% of the world's cases and 22% of the world's deaths. In contrast, California has about 12% of the United States population, and it has about 12% of the US cases and has only 7% of the US deaths. California has actually had a lower death rate than the United States as a whole, significantly lower. And San Francisco is the lowest of the large metropolitan cities in the United States. It has the lowest death rates. And if there's time, perhaps we can talk about that. If we bore down a little more deeply and look at Alameda County, where we are, the number of cases and the number of deaths also are not equally distributed. In one of the slides I wanted to show you, the certain zip codes have a much higher percentage of cases. And those zip codes are primarily East Oakland. And it's largely a lower socioeconomic group, and it's largely a Latinx group of people. And if we look at Alameda County in terms of the ethnicity and race and the number of cases and the number of people infected, we find that the African American community in Alameda County has about represents about 1% of the population is infected. The Latinx community has about 3% of the population infected, whereas the white community has about 0.4%, and the Asian community about 0.4%. So the African American community has about a little over twice the number of people infected per capita as the white community. The Latinx has about 7 times as many. Because the numbers in Alameda County have dramatically dropped, Alameda County is one of the three of the 6 Bay Area counties that have done remarkably well recently. For over 3 weeks, the Alameda County's percent positive is about 1.4%. California as a whole is about 3.6%. So we are having far fewer cases.
Okay. You sent it. Okay. You sent an email or you text me?
I emailed it to you.
Okay. All right. Bye.
You're welcome. Santa Clara County and San Francisco County are doing really well, like Alameda County. Contra Costa County and San Mateo County and Marin County are not doing as well. So this translates into Alameda County, along with San Francisco and Santa Clara, entering what's called the orange zone. It goes purple is the worst, red is the next worst, orange is moderate, and yellow is minimal. So we've now gone from the red to the orange zone, which means that some indoor businesses and operations are open with modifications. Interestingly, if we contrast Alameda County with Santa Clara, both in the orange zone now, Santa Clara is opening up much faster in terms of restaurant indoor dining and in other activities. Alameda County is taking a more conservative approach, and that is it has not really changed very much. A few things, but not very much in terms of the status that we had when we were in the red or substantial area. So Alameda County, as I said, is taking a more conservative approach. And frankly, I agree with that, given some of the disturbing numbers that we're seeing that perhaps we can talk about in the Q&A, numbers in terms of how many cases are increasing nationally and internationally. So I'd like to turn now to look at and try and answer the question, what are the major drivers of why we're having such a terrible problem controlling this pandemic? And there are really four things. One is the dispossessed have a disproportionate number of cases. And I'll come back to that a little later in more detail. Incarcerated people have a disproportionate number of cases. People who are living in long-term care facilities like nursing homes, and what are called super spreading events. Those four things, dispossessed, incarcerated, living in congregate settings like nursing homes, and super spreading events, are the four major drivers of this pandemic in the United States. If we look at the dispossessed in a little more detail, we know that the likelihood of dying from COVID-19 is increased tremendously by socioeconomic vulnerability. For example, if people have severe housing problems, they're about 5 times the risk of dying for people who don't have severe housing problems. If you're unemployed, you have about 2.5 times the risk of dying. If you're incarcerated, about 2 times the risk. If you live in poverty, 1.4 times the risk. If you're food insecure, 1.4 times the risk. And if there's a lot of stress in your neighborhood, 1.4 times the risk compared to the general population. So clearly, being dispossessed in our society drives the mortality rate greatly. If we look at the age-adjusted COVID-19 associated hospitalization rates nationally, we see that the three highest groups are Latinx, African American, and American Indian / American Native, all about 3 times higher than Asian and Pacific Islanders, and about 4 times higher than white non-Hispanic. So again, this pandemic is not evenly distributed throughout our population. The other event that I wanted to talk about are what are called super spreading events. What this means is that somewhere between 5 and 20% of those people infected are the cause of about 80 to 90% of all the cases. So there are events, there's nothing about the individual infected that we know that is causing that disproportionate number of spreading, but it's probably the circumstances in which an infected person is in when that infected person is most contagious. So let me give you a couple of examples of 3 examples of super spreading events. One is the Sturgis motorcycle rally that took place in September. There were 460,000 people in that small town of South Dakota over 10 days. This resulted in around 250,000 secondary cases, and 20% of those occurred within a 1-month period of time. The costs to society was estimated to be about $12 billion for that one event, a super spreading event. Last time I talked to you, we talked about the fact that COVID spreads easily in group gatherings. And there were 3 events that I mentioned to you in terms of churches where super spreading events occurred. 2 symptomatic people at one church who attended church services in March later spread the disease to I think it was around 68 people. Another event that took place, at least 35 of 92 attendees acquired COVID in a church event, and there were 3 deaths. And the third was from contact with church cases. At least 26 additional cases were confirmed and 1 death. So That has to do not specifically with churches, but it has to do with congregate settings where people aren't wearing masks and social distancing and where singing takes place. And I mentioned singing because yesterday there was a report of a super spreading event that took place in Switzerland in a yodeling concert. And this was blamed for a lot of cases of people who attended that concert. And yodeling has been studied as a way of aerosolizing a lot of particles, just like singing. I'd like to just bring us up to date with what we know about transmission. I think everybody's aware that the most common means of transmission for this virus is what we call droplet transmission, which means that when we talk or yell or scream or sing, that we expel droplets from our mouth primarily. Certainly when we sneeze, it'll come through our nose as well. Those droplets that are expelled tend to be large, heavier than air, and drop to the ground usually within a matter of moments. So if you're within 6 feet of somebody, you could get those droplets on your eye, nose, or mouth, and that's how you would become infected. You would inhale those. What we also talked about last time was if we put our hand on an inanimate object, or we shook somebody else's hand and then took our hand and moved it to our mouth, nose, or eye, we could become infected that way. We think that's not a very important means of transmission, but it can occur, and that's why we continue to stress hand washing. What I think has changed since we last spoke was another form of transmission that's called aerosol transmission. And that's where some of the droplets that are expelled when we talk or cough or sneeze or sing, some of the droplets, not as many, are very, very small. They're lighter than air, and they can stay in air for long periods of time inside without a lot of air exchanges for a number of hours. And they can travel a lot further than 6 feet. And there have been documented cases, including some of the instances I mentioned with the church outbreaks, that have occurred by this aerosol transmission in people much further away than 6 feet. They are much less common than what we see with droplet transmission or the 6 foot transmission diameter. But they do occur. And we can talk about the clinical significance of that perhaps later in the Q&A. I wanted to also talk about and update you with what we understand much more today than we did in June about asymptomatic spread. We know that the percentage of infections that are spread by people who are asymptomatic are about 40%, or to say it another way, of 100 people who get infected, about 40 people will have no symptoms at all, but they still can spread the virus. We also didn't know at that time very much about what's called pre-symptomatic spread, which means that people are contagious before they become symptomatic. We know the peak of contagion for somebody with COVID is about 12 to 24 hours before they become symptomatic. So people would go out and do the same things that they would normally do and not think they're infectious because they feel fine when they actually are, and they'll become sick perhaps a day later. So the other statistics that evolve from this asymptomatic and pre-symptomatic spread are that the infectiousness of an asymptomatic person relative to a symptomatic person is about 75%. The reason why it's so much higher is not because you're shedding so much more virus necessarily, but because when people aren't sick, they're not taking as many precautions. And the percentage of transmission occurring prior to symptom onset in the pre-symptomatic setting is about 50%. So 50% of people who are in the pre-symptomatic stage of their infection before they become symptomatic spread their disease at that time. So this tells us how important it is to practice precautions even if we feel completely well. We talked last time about the natural history, and that hasn't changed too much. If we take 100 people with infected, we know that at least probably half of the people, at least 40%, don't develop any symptoms at all, as I mentioned before. Of those people who develop symptoms, the vast majority get well and don't require hospitalization, but about 20% do. And of those people who get hospitalized, about 85% will recover. The 15% that don't recover, about half go to the ICU, wind up in the ICU. And of those, about half will die. So if you break that down, of 100 people who get infected, we know that the mortality rate for all comers equally distributed throughout society would be about 0.7%. But it's not equally distributed, as I suggested to you before with some of the numbers about how it's really maldistributed. One of the things that we've learned a lot about since I last spoke to you was that there are long-term consequences to COVID that we didn't really appreciate early on in the pandemic. We know the classic signs and symptoms of the acute infection, but what we're starting to appreciate now is that people are having chronic problems. They're having their lungs scarred, which will probably last the rest of their life and lead to some degree of limitation of respiration. Chronic fatigue has been a major problem, occurring in up to 60% of people 3 months after their infection. And a lot of these people had a minimal infection, but they have chronic fatigue afterwards. People have described brain fog is associated with that, meaning that they just don't seem as mentally sharp afterwards. Most of the time that gets better, but we don't know if it always will. There are other central nervous system complications that have been recorded, including, of course, stroke. And some of these consequences seem to be permanent. The loss of smell or phantom smells can persist long after the acute infection. And in some people, we're concerned that it may be permanent. There are psychiatric complications that occur both acutely and chronically, the most important of which is depression. And that seems to be a growing problem in society. The heart complications are of great concern. There was a paper published in July from Germany that suggested that in the population of people in their 40s and 50s, about 60% of people had evidence of inflammation in their heart 2 months after their infection. Nobody else has repeated the studies that have shown that kind of instance. In Ohio, at Ohio State University, there were 24 athletes, most of whom were football players, who had COVID, and 15% of those, I think that was 4, had evidence within about 2 months after their infection of inflammation of the heart. And this is of great concern, of course, with athletics in general, and that is, what should we be doing with people who have had COVID and now seem perfectly fine? Should they be stressing their hearts? And perhaps you'll have some more questions about that. The other long-term consequence that we're worried about is increased both morbidity, how sick people remain, and mortality from other diseases that they normally wouldn't have died from. What I mean by that is that we've seen a large spike in people dying at home of diabetes out of control, and people dying at home of heart attacks because they've been afraid to go to the emergency room because of the pandemic. We've also seen a dramatic drop in the number of people being screened for cancer because they've been afraid to go to those medical facilities that are doing the screening. And there's a great concern that with the drop in screening for cancers, that we will have an increased cancer mortality a few years down the road. So those are some of the sort of unseen consequences to a COVID infection. I'd like to now address diagnosis. We really have 4 different ways that you can be diagnosed with this disease in terms of where we can get the sample. The one that you've most heard about, and we talked about before, was what's called a nasopharyngeal or NP culture. That's our sample. That's where we take a long stick with a little cotton pledget at the end and stick it through your nose all the way back to your throat. Very unpleasant. I'm sure a lot of you have had that. More recent data has suggested that you can just go about an inch in, and that may be just as good a yield. And there's some data that suggests that you can just culture just inside your nose at the tip, and that may be adequate. There's emerging data that saliva may be a good source as well, although that data remains still preliminary. But it would be nice if we could just spit into something as opposed to having something stuck into our nose. I wanted to review with you a little bit about what we've learned since we last talked about diagnostic testing. There are 3 different types of diagnostic tests that are widely used. One is the first one that we started using when the pandemic began was what's called a PCR test, or a polymerase chain reaction test. It's a fancy term for just saying that we take the sample and we put it through transcription, and we keep amplifying the amount of material that we found. In this case, the material is the RNA, the genomic parts of the virus, and we amplify it until we can identify it. That's considered the most sensitive test and the gold standard. Another test that is being widely used for diagnosing infection are called antigen tests. And these are tests that we get the same samples from the same place, but we'll take those samples and we'll look for little bits and pieces of the protein of the virus. So not its genome or not its RNA, but little pieces of the virus. And that's what we call the antigen, and detect that. Comparing these 2 tests, the PCR tests are much more sensitive. That is, they're less likely to be falsely negative. The antigen tests are less sensitive, but they're a lot less expensive, and they can be done a lot more quickly. The hope is that we can be doing antigen testing or PCR testing very inexpensively at home without having to send them to a lab. And I think we're going to see within the next 3 to 6 months that we're going to develop the technology to be able to do that. So for perhaps less than $1 a day, we could check ourselves on a daily basis. And either one of these tests should be adequate for that. And we would pick up when we become positive, and that would dictate to us that we now need to go into isolation. It could really have a profound effect on knocking down the number of cases of this infection. The last test that I wanted to mention of the 3 is called the antibody test. And this is the one I would essentially forget about, because it only becomes positive, the antibodies only become positive. These are the proteins that our immune system produces to combat the infection. It becomes positive about 2 weeks after the infection. So it's not good for diagnosing an acute infection. It is perhaps good for telling us if we were infected in the past, more than 2 weeks ago. But I don't think it's worth anybody spending their money on, because there are a lot of false positives with this test. That means it will say that you have been infected in the past when you haven't. And we don't know if having antibodies in your blood means that you're protected, because when we get infected, we produce all different types of antibodies, some of which don't protect us, and some do. And these tests that you would get for an antibody test measure all the antibodies or just some of the antibodies. So it doesn't tell us whether we're protected in going down in the future. So we can't use this test to say it's a get out of jail free card. In terms of treatment, There are two widely used treatments. One is called dexamethasone, which is a corticosteroid, and the other is called remdesivir, which is an antiviral agent. These are the only two approved drugs in the United States for the treatment of COVID. Dexamethasone has been shown in people who are very, very ill, require continuous oxygen therapy, either by a mask or by having a tube down into your lungs and being on a ventilator. And it's been shown to reduce the mortality rates in those people modestly. It has not been shown to reduce mortality rates in people less sick. The other is remdesivir, which, as I mentioned, is an antiviral agent, and that has been shown to reduce hospital stay from 15 to 11 days. But a study that no one has seen yet, and it hasn't been peer reviewed, but was announced, I think, 2 days ago from the WHO, or from Europe, suggested that the people who received remdesivir did no better than people who got placebo in terms of reducing deaths. So that was very disappointing. It has to be reviewed by people who didn't have a vested interest in the study. So it's got a long way to go before we're going to buy those results, but it is very concerning. There are a couple of other promising drugs. I won't go into those in detail right now, but if you have questions, I'd be happy to address them. There's some with mixed evidence. There's some that aren't promising at all, like hydroxychloroquine. And there's some pseudoscience or fraud drugs that continue to be promoted, both for treatment and prevention, none of which have been shown to work, but people are spending a lot of their money on. So right now, we really have drugs just for those people who are quite ill. And the only one that is unquestionably reduces mortality rate is dexamethasone for those people very seriously ill. I'd like to turn now to how we're trying to prevent people from getting infected. You've heard the mantra about social distancing and masks, and I'll just mention social distancing. Right now, the United States, we're about 20% less mobility, social mobility, than we had before the pandemic. At the height of the lockdown here in the United States, we were at about close to 55% of the amount of social mobility. So we're being less careful now than we were in April and early May. And I think many of you may remember the picture from Memorial Day of people in Arkansas crowded together. And I have another picture on the slides of Costa Brava in Spain, people on the beach crowded together. So people aren't really practicing as well as they need to be social distancing. And masks is really a no-brainer. It's been estimated by several groups that without wearing any masks, sometime by the end of January, we'll have about 4 million deaths. If we wore masks, we would dramatically drop those numbers. As a matter of fact, if there was near universal mask use, we would cut in probably about half to 2 million deaths, the number of people dying from COVID, because we're going to prevent that number of infections. So masks really do work. There is really no question about it. I'd also like to talk about, in terms of prevention, some terms that I think are confusing and some updates on these. One is isolation. What isolation means is it's for people who are diagnosed with being infected or diagnosed with being sick from the infection, and we put them in isolation. We isolate them from people who are well. What's changed since we last talked is that we've learned that roughly about 10 days after a person becomes infected, or after a person becomes symptomatic with that infection, they're no longer contagious if they don't have any fever for at least the last 24 hours, and their symptoms are much better. So you can come out of isolation 10 days after you've been diagnosed with infection or disease, as long as you're feeling much better the day before or day 9. If you're seriously ill, or if you're an immunocompromised person for any reason, then we extend that to 20 days. You have to remain in isolation for 20 days. The other term is quarantine, which is not isolation. What quarantine means is that if you're exposed to somebody who might be infected, if you had a significant exposure, which we define as 15 minutes or more within 6 feet of somebody who's infected, you need to go into quarantine for 14 days. Interestingly, there's an ongoing debate at the CDC right now as to whether that is too many days. And there's the hope that we might be able to reduce this number to 10 days or maybe even 7. But right now it's 14 days if you're exposed. So it has nothing to do with being infected. I'd like to address very briefly vaccines. There are multiple different types of vaccines that are being developed. Some have never been tried before in human beings. Some are based upon vaccines that we've had for decades. Right now, there are no vaccines worldwide approved for full use. In China and Russia, there are vaccines that have been approved for use. None of those vaccines have gone through phase 3 trials. And in my opinion, they're being used very prematurely in their populations. We can't possibly understand the degree of efficacy those vaccines have, and very importantly, their degree of safety. There are 11 vaccines worldwide that are in phase 3 trials. Here in the United States, we have 3 major ones that are in phase 3 trials that are ongoing. 2 of those phase 3 trials have about 30,000 people in them, and one of them has about 60,000 people in them. We may get results from those trials at the earliest by the end of November. Probably more likely in December, we should have some results. There are lots of unknowns about these vaccines. And if you would have questions about that, I'd be happy to discuss those with you. But we know, for example, that, or we don't know, how well these vaccines are going to work, how well they're going to protect us. And we won't have long-term safety data. We'll have relatively short-term safety data when they're first released. So there are some genuine concerns about all of these vaccines, and I hope there's some questions about those that we can talk about. There's also questions about how they're going to get distributed. The National Academy of Science came up with a draft plan about five weeks or so ago that they considered 4 phases. The first phase would be those people that are high-risk workers in healthcare facilities and first responders. It would be for people at all ages who have underlying conditions that put them at higher risk for dying, and older adults living in congregate settings like nursing homes. That would be the first phase, and then the next phase would be more and more people could be phased in, like teachers and school staff, critical risk workers in industry, people in homeless shelters, people in prisons. And then phase 3 would be younger adults and so on. So it just phases in, and probably those phases would take at least 9 months minimum. So I think we're talking about, if we had a vaccine that was approved, or vaccines more likely that are approved in the first quarter of 2021, it'll probably be around this time next year that most people who want to get vaccinated would be vaccinated. I'd like to conclude by asking the question, why have we done so poorly in the United States? 4% of the world's cases, 4% of the world's population, 20% of the world's cases. There's a real question that perhaps Americans have the wrong culture for a pandemic. This very individualistic culture, the lack of appreciation for the fact that pandemics need to be controlled by in a coordinated fashion, not in a haphazard fashion, is very difficult, I think, in particular for Americans. I think another problem tucked into that is that for many Americans, the pandemic is invisible. What I mean by that is that a mathematician estimated that each American on average knows 600 people. That would mean that for every American to know somebody who has died from COVID, if the disease was equally distributed in our society, it would mean that we'd have to have about 500,000 Americans dead for every American to know somebody who's died. But of course, the infection and the disease is not equally distributed throughout our population. So asking people who come from more privileged backgrounds, higher socioeconomic class in our society, they're less likely to know people who have died of COVID than people who come from the higher risk groups in our society. And this leads to the fact that unless you know somebody who's died, I'm going to word it differently. Unless you have tremendous empathy, it requires knowing somebody who's died to really change how you approach this problem. And I'm afraid that a lot of Americans don't have sufficient empathy for what's going on. Another problem, another explanation for why we're doing so badly is that there have been decades of underfunding of public health. This didn't begin with the Trump administration, although it was exacerbated by it. This has been going on for at least 3 decades in the United States. Another problem is that we have a completely fragmented healthcare industry. So it's near impossible for the United States to do things to combat this pandemic in a coordinated fashion. Another problem is that we've had disastrous messaging. Just absolutely disastrous. The president has stood up and lied to us on a daily basis about this pandemic, as well as about so many other things. He has a health advisor now, Scott Atlas, who is a neuroradiologist who knows absolutely nothing about public health or infectious diseases, and that's his major advisor. Another problem is that there's been inadequate testing from the get-go, and that we've never completely caught up. We're still not doing enough tests to mitigate the pandemic, much less suppress it. Another problem is that there's an inadequate amount of PPE for our healthcare workers. That is still a problem. We still have to ask people not outside of healthcare not to wear N95 masks because there's just not enough of them for our healthcare workers. And the last problem is that there's been tremendous politicization of our key agencies like the FDA and the CDC. The CDC is an agency for my 50 years of being a physician, I have always had the greatest admiration for. But I can no longer trust the messaging out of the CDC, not because the people who work there are not trustworthy. They are absolutely trustworthy. They're magnificently trained and completely dedicated. But that the leadership of the CDC has been taken over by the Trump administration. And unfortunately, the same can be said for the FDA. And all of these problems that I've listed, they're not things that I've just made up, of course, that people who follow this kind of problem, and frankly, the lay public, I think is well aware of all of these issues. And I want to conclude by just reading a very short paragraph from the New England Journal of Medicine. arguably the most prestigious, I don't even think arguably, I think it's the most prestigious general medical journal in the United States, if not worldwide. And about 2 weeks ago, they had an editorial from the editors called Dying in a Leadership Vacuum. And in the, I think, 160 something years of publication of this journal, the editors have never written an editorial like this. And the concluding remarks were, truth is neither liberal nor conservative. When it comes to the response to the largest public health crisis of our time, our current political leaders have demonstrated that they are dangerously incompetent. We should not abet them and enable the deaths of thousands more Americans by allowing them to keep their jobs. So I'm through, and I'm sorry that I couldn't share my slides with you, but Deacon Goodman has them, and I'm happy to have you, if you correct a couple of the spelling errors I had on them, share them.
But we have Reverend Charlotte. She's great at that. She'll handle that for us.
Okay, thank you.
Yes. Yes. Well, thank you first off for your presentation, Doctor. There were some questions that were presented, and some of them were answered in your presentation. We would like to see if we can have some of those specific questions that were asked. Are you ready to do that? Okay, great.
Would you like me to read them?
Go ahead. My question was going to ask, would you like me to read them, and then you
I prefer that.
Answer them?
So
Tell me how you prefer. Yes. Okay. So I'm just going to ask the questions, and then we'll go from there. And some of them you may have already answered, but they're very specific. So if you don't mind, we'll proceed with that. So one of the questions that was provided to us was, what's more important to obtain control of the pandemic? Wearing a mask or taking the vaccine?
Wearing a mask or what?
Taking a vaccine.
Vaccine, got it.
A vaccine.
Well, wearing a mask is, I'll tell you why I can't answer this question, is because I don't know how efficacious the vaccine is going to be. I can tell you that if you wear a mask and you social distance, it'll work very well to prevent you from getting infected. It'll just about it won't give you 100% guarantee, but it's going to give you a very high degree of assurance that you won't get infected. And of course, no one's going to die from wearing a mask or social distancing. So it's completely safe and it's highly efficacious. Vaccines, the criteria for a vaccine being released is that it has to show at least 50% efficacy, and it has to be shown to be safe. Let me drill down on that a little bit. Efficacy can be defined as preventing you from getting infected. That's very unlikely that we'll have a vaccine that'll prevent us from getting infected. But it's highly likely that we will have a vaccine that'll prevent us from getting sick. So that would be defined as efficacious, and that would be good, although you still might be contagious. But efficacy could also be defined as that it'll prevent you from dying. That is, it won't prevent you from getting sick. It may not prevent you from going into the hospital, but it'll prevent you from going into the ICU and dying. That will be considered to be efficacious. So I need people to think about that, because even if it's 70 or 80% efficacious, but its efficacy is defined by preventing you from dying, but not from getting sick, is that going to change our behavior very much? What I'm getting at is that I think that even if we have a vaccine, we're still going to be needing, until we get rid of this virus, we're still going to be needing to wear a mask and social distance.
Thank you for that. I'm thinking we're going to have a lot of outfits at the when we buy our clothes, we have masks attached, matching masks attached to it for a while, probably. Thank you for that. So wearing our masks is going to be very, very important for a long time, sounds like. Another question. I'm a patient with multiple underlying health problems. I have tested negative for COVID-19. How often should I be tested?
You don't need to be tested at all because the testing won't change anything. This is for all of us, and especially for people who have underlying health problems. If you get tested today, it will tell you if the virus is present in you at that moment in time, but it won't tell you what's happening tomorrow or the next day. What I mean by that is if I got infected today, if I inhaled the virus today, my test wouldn't become positive until probably about day 4, maybe day 5.
Mm-hmm.
And so I could be infected. If I got tested tomorrow, it would be negative. If I got tested the next day, it would be negative. And the next day, it likely would be negative. And it probably wouldn't be positive till mid next week. So getting tested isn't going to help decide what you're going to do.
Okay. All right. Thank you for that. Okay. Another question. I was swab tested for COVID-19. Should I do a blood test just as well?
No. The blood test is the antibody test, and I talked about that. And it's broken my heart that people have thrown their money away for that test, because there are very few instances where it's valuable for the individual to get the test done. Where it can be used is to tell us how many people have been infected in the past. Tell us what's called the prevalence of disease. So epidemiologists use antibody testing to give us an idea of how many people have been infected. So, for example, we estimate that roughly about 10% of the American population has now been infected based upon antibody testing. That means that 90% of us are still susceptible.
Okay. Okay. All right. Our next question. I have many underlying health problems. As a daily routine, I check my blood pressure, oxygenation level, peak, flow, heart rate, and temperature. What health check results should trigger my concern about COVID infection?
Well, I think there's a distinction between being infected and getting diseased. And as I mentioned, about 40% of people who get infected don't know it. They're not diseased. The disease COVID is characteristically fever, cough, some shortness of breath, and body aches. Often with a headache. So it looks an awful lot like influenza. So I think that if you get any of those symptoms, you should check in with your physician and ask what you should do. What I would suggest is that if you're not very sick, you don't need to be examined because there's nothing that's going to be changed at this time. That if you develop furthering shortness of breath, you definitely need to be seen right away. And a lot of people are purchasing what are called oximeters, which you put on the tip of your finger, measure the amount of oxygen saturation in your blood. And you can monitor that if you're sick. And if you see the oxygen saturation dropping, that's a sign that you should immediately contact your doctor or perhaps go to the emergency room and get checked out.
Okay, thank you for that. Thank you for that. We have another set of questions that we believe that some things that people might have on their mind about getting back out into the world. So it's going to be about guidelines. So what guidelines would you recommend for deciding when and under what conditions to return to places of worship?
Well, I think right now the guidelines, in Alameda County, the guidelines are maximum of 100 people or 25% of the capacity of the church or place of worship. And that is, that's a conservative guideline, but it seems a prudent one. So I think, I feel the guidelines are clearly saying, and I completely concur that churches should be open. We should curtail the number of people that participate in church services. And singing really is a problematic issue, which I think is so important in all the way so many people worship. So that's my answer right now. When should we liberalize that, or when should you feel comfortable about having more than 100 people, greater than 25% of capacity? I think that the answer to that is it depends how we're doing in our community. If Alameda County, or if the Bay Area or California continues to do as well as we're doing right now, I think things should be liberalized, and I think we should partake in more activities like religious worship. But I'm very worried right now about that, and I'm worried about it because when I spoke to you first, we were having in the United States, we were having about 20,000 new cases reported a day. In the last roughly week in the United States, we're now having 60,000 new cases reported a day. So we're going in the wrong direction, and we're going pretty rapidly in the wrong direction. Part of what's going to drive that worse and make it even worse is the fact that when the weather, if it ever does here, if it starts to cool off, people are going to be spending more and more time inside, and we know that inside is a far riskier place for getting COVID than outside, because outside the virus gets diluted in so much air. Inside it doesn't get diluted as well. So I think that we're going to be seeing a lot more COVID late fall and winter than we're seeing now. So I think now's the time to remain very vigilant with things like places of worship, and to be very careful in terms of liberalizing things.
Okay, I did hear you also reiterate the fact that the public health officers or the county are who really makes the guidelines for us to all follow. And each county has their own guidelines, but these are questions just asking for your insight. So don't feel like we're holding you to anything that's extra, but good information about that. We need to stay vigilant, even with everything looking like, especially with it going up and down as it has. There were other questions about the guidelines as well around returning to indoor restaurants and returning to gyms and other workout facilities and going back to traveling in the air. Do you have any thoughts around those things, as Dr.?
I do. Very much in line with what I was just saying about places of worship. Everybody has their priorities in life, and where some people may prioritize going to places of worship, other people may prioritize going to a gym. I think that, and this is a personal opinion, I think that to mitigate the spread of this infectious disease, we ought to be being very careful in choosing what we do that puts us at greater risk. And for example, indoor dining is something I really enjoy. My wife and I love to do that. But there's no way am I going to go inside a restaurant to eat for a couple of hours, most of the time without my mask on, ostensibly 6 feet away from other people, but in a closed space. I think that's a very high risk activity, and I can live without going to a restaurant, although I'd really like to. I have a gym 5 minutes from my house, 10 minutes by walking, that I love to go to. My wife and I have gone there since it opened up about close to 20 years ago now. It's going to open up again, and my wife and I are not going to go. even though we love going there. I just don't think it's worth the risk. I'm going to exercise at home or walk outside now that I can again, or we can again, because the air is better. I have a daughter who lives, and her family, 3 grandchildren who live in Virginia. We haven't seen her since last Thanksgiving. And we're reluctant to fly back there to see her. And we're very reluctant to have her fly here to see us. And yet it's extremely painful not to be with our daughter. So I think that each of us individually has to look at the guidelines and think about them and prioritize them in our own minds for us, and pick the things that may put us at increased risk, but that are so terribly important to us. And those are the things you would choose to do.
Okay. Thank you for that. We have to kind of make our own decisions, but being cautious and thank you for that. Along the same line a little bit is around if having any guidance around parents with school reopening.
Yeah, I don't think there's any question that schools reopening are terribly important for our children, to allow parents to get back to work, for the mental health of our children, much less their learning, for the socialization of our children. There's a tremendous amount that's being lost by not having schools open. People say that it's an experiment to open up schools, and that's absolutely right. It will be an experiment because we don't know how safe it will be. But it's also an experiment to not keep schools open and to experiment on children that way. This is a very tough call, and it is often a difficult call because in school districts or private schools that have lots of funding, they can find the space, they can find the resources to mitigate much of the risk of having children go back to school. In most of our public schools, certainly in the Bay Area, they're underfunded. They've been underfunded for a long time. They're overcrowded. They don't have the resources to effectively mitigate the risk that schools with more resources have. It would be terrible to open up certain schools and not open up others, because it would just further divide our population and deprive a significant swath of our population of the education, socialization, and mental health that they need. So I think that we have to open up schools very cautiously. We have to make sure we've mitigated the risk to the extent we can. But as a society, we have to allocate more resources to our schools to make sure that they can do it safely. And we haven't been doing that.
Okay. The schools, we have to be really careful. The babies do need the socialization. It's very important for them, but we want to be careful. Around the guidelines and things of that nature is a question about, is it safe to go back to routine dental appointments and other medical appointments?
Yes, I think it is. I've gone back and had my teeth cleaned. I went back to see my audiologist. So yes, I think it is safe. The reason why I say that is because all the medical societies have put together protocols to really make these environments safe for us. Now, they're not 100% safe, but if you contrast, for example, I don't want to be losing my teeth, which is going to decrease my ability to get good nutrition. So I would prioritize dental health over the very small risk of going. I would go through cancer screenings. And if you have ongoing medical problems, I would work with your doctor, ideally by telemedicine, but sometimes you need to be seen, and I would not hesitate to be seen. I think you have to keep in mind, again, to prioritize the importance of your health, maintaining it with your physician, versus the, I think, very small risk of being out in going to a clinic.
Okay, so get those dental appointments in and the other medical appointments that are routine that we need to have. It's important to still do those. Just take all precautions.
Right.
Okay. Can pets contract COVID-19? And if so, can the COVID-19 virus be transmitted to from pets, by pets?
There's some evidence that dogs and cats can get COVID. They've gotten them from the humans that they live with. There's no evidence that the animals can transmit it to humans. And I can't say 100% that it's no risk, but I think there's no evidence that it's ever happened. So I don't think that's a big issue. I wouldn't worry about it.
Okay. The next set of questions is around masks. Let's see. The first one is there any difference between the N95 and the KN95 or KN94 masks?
I'm not sure. The N95 mask is the one that's been approved. I looked up a while back what the KN95 was, and I don't remember what it is. So I'm not going to answer. I won't answer that one. I can't answer that one. Sorry.
Oh, no worries, no worries. Actually, the little bit of research I have done is that, and I'm not a doctor, but I have been a medical social worker for many years and have had some contact, of course, in hospitals and healthcare, home health. But the little bit I do know is that the KN95s or KN94s are actually because if you notice them, if you get them, the packaging is in Asian or Chinese or different writing. That's their reportedly slightly equivalent, not for us here in the United States, but it still is very helpful. It's better than no mask. But it's my understanding that's the Asian kind of equivalent to our N95. Something along that lines. But do your research and ask your doctors about that. Thank you, doctor, for your being safe on that. I'm just sharing what little research I did have on that. Another mask question is, can you get carbon monoxide poisoning from wearing a mask?
No. Absolutely.
Okay. All right. If someone sneezes while not wearing a mask, but spraying Lysol, after that sneeze, will spraying Lysol or disinfectant spray right away kill the airborne germs?
No one to my knowledge has studied that. And I think the chances of that working are extreme. Spraying Lysol or any disinfectant is very, very small. So I don't think that's going to help.
All right. So again, reinforcing, please wear those masks. That's going to help us a lot. Now, the next set of questions I see so far is around the vaccine that everybody's working so hard to get so quickly for us. When do you realistically believe we will have a vaccine?
As I think the first quarter of 2021, and there'll at least be one, and I suspect there'll likely be more than one approved for use. So I would guess January, February, maybe as early as December.
All right. We just have a little more time to go potentially. What will the distribution channels of the vaccine be? Like medical doctors, clinics, CVS? Do you have any idea around that?
There's been a great deal of discussion about that. It depends on which vaccines and how they have to be delivered. By that I mean 2 of the vaccines require minus 70 degrees centigrade temperatures, which can't be achieved easily. So that would really make distribution difficult. People are talking about having the military play a role in distribution of the vaccines. I don't think we know yet how they're going to be distributed.
Okay. Will herd immunity be as effective as a vaccine? If no, if so, why? If not, why not?
Well, you can listen to my debate on KCBS later today, where I debated yesterday somebody who was a signer of that Great Barrington Declaration. I think it's a dangerous idea, and that's the idea that we should let people just go out and do what they want to do and get infected, except for those people who are at high risk. And people who are at high risk would be sequestered away from the rest of society. The problem is that about 60%, 40% of the American adult population is high risk for dying. So you'd be sequestering 40% of the population, and so many homes are multi-generational, and it suggests that that people at high risk in those homes should move elsewhere. It's frankly an appalling suggestion that will result in estimated probably close to 1.8 to 2.2 million lives that need not be lost. So I think it's a horrible thing that they've done. You can tell I feel strongly about that. The idea that they're basing it on is what's called herd immunity, and that is if you have enough people infected, the virus won't have a place to go because everybody will be immune, or so many people will be immune that the virus can't find a new home. There are problems with this idea of herd immunity. Right now, as I mentioned, we're at about 10% herd immunity. It's estimated we need about 60 to 70% herd immunity to suppress a virus that spreads like this one does. So we have 200 and almost 20,000 deaths in the United States, and at 10% of the population being infected. You can do the multiplication to get to 60 to 70% of the population at herd immunity. You'd multiply it by 6 to 7 times 220,000. And you see, you're talking about an awful lot of human beings dead from this virus. So waiting to get to herd immunity by natural infection is a mistake. But getting to herd immunity by vaccinating people makes a lot of sense. And so I think that what we need to be doing is to be doing the same things we're doing now, except better, much better than our government has been doing for us, our national government, but doing the same things we're doing now, just much better. Social distancing, masks, slowly bringing people back into the workplace when we can. If things get worse, bring them back out of the workplace and so on. And at the same time, like we're doing, try to develop effective vaccines that are safe and therapeutics that will work much better. So I think that has to be our approach.
Yes, so that's what we're listening and doing those things for sure. I think this is the last question, unless there's some other questions. Please, we don't want to leave anyone out. So if you have any questions, please.
Unfortunately, I am going to have to run. I'm giving a talk at UC Berkeley, and I was supposed to be there 5 minutes ago.
Is it at all possible just for me to ask this last question, Doctor?
Sure.
Okay. With the comments on mistrust of the CDC and the FDA, why should we take a vaccine? And will it still be a 2-dose regimen or regime?
Sure. All the current vaccines that are in trial in the United States right now in phase 3 trial are 2 doses. That's an easy one to answer. Why should we trust the CDC and the FDA and the White House? I think that's a very fair question, and I think the answer is if the vaccine that comes out is safe and efficacious, then independent people, groups like the Infectious Disease Society of America, like the American Public Health Association, like medical journals, like public health professionals, like physicians, societies like the American College of Physicians, and so on, will independently scrutinize the data. And if all of those societies say this is safe and this is efficacious, I'm going to roll up my sleeve. But if those societies say no, this has been politicized to help the president get reelected or whatever, then I would pay attention to those independent people reviewing it right now. And I pray that we're going to get to the place in our society again where we can trust our institutions.
Yeah. Well, Dr. John Swartzberg, we really appreciate you taking the time to be with us today. We heard you. You got to get to that next presentation. So please go ahead, be safe, drive and get there safely and have a great presentation there. And we thank you for the wonderful presentation you've provided us with all the information you have today for us. Thank you so very much.
And I want to thank you very much for giving me the opportunity to speak to you. It's always very special to me to do this. And I hope you'll extend it to me again when we'll have more positive things to say. Goodbye, everybody.
Thank you again. So everyone, we have had some very good information around mask wearing, around the vaccine, and everything else that was presented. You will receive a link. Those of you who registered for this particular presentation, you will receive a link at the end of this presentation. In addition to that, you will receive the slides that Dr. Swartzberg was referencing. Due to some technical difficulties, unfortunately, we were unable to put those up for you as we had planned, but you have registered, you will receive those as well. And then lastly, you will also receive after this time the 2 brief surveys that I referenced at the beginning of our time. If you complete those surveys by 6 p.m. this evening, you will be put into a drawing to receive one of 4 of the $50 gift cards. So please, we'd like to hear and get your input. Your input assists us with directing and providing, putting together our educational goals for the next year. So again, those surveys will come out to you at the end of this program as well. Please email them to healthed, HEALTHED @allen-temple.org. We have a few announcements I'd like to share with you about some future events as well. We can have those announcements. Let's see. One is our Black Health Matters event, which will be on Saturday, November 14th, 2020 at 10 o'clock to 11:30 a.m. Please see the flyer there. Check our website, our Allen Temple Baptist website, our Facebook page for information about our Black Health Matters event. We hope to see some of you there. Our next announcement is that we want to let you know about our partnership with the Lion Club of Marin County, partnering with us to provide free eye exams, eyeglasses, and potential eye surgery. The services will be available in Alameda County, Contra Costa, and Marin counties. There are certificates of service for both youth and adults. So if you're interested, email healthed, that's HEALTHED, @allen-temple.org. Leave your phone number and we will reach out to you. We hope to help some persons in the community with their vision. With that, we had a very informative and educational time together. We're going to now turn this over back to Deacon Harold Goodman for our closing remarks, our chairperson. Thank you.
Thank you, Ricka. Thank you for being such an outstanding moderator. I would just like to say once again how grateful I am to be able to work with the health education ministry and provide information of this nature. More specifically, the leadership from our pastor, who was very supportive, and my leaders of my cluster, both Reverend Theo and Deacon Michael. And with that, I'd like to turn it over to Deacon Michael Johnson for the benediction.
Thank you, Deacon Goodman, to all of you members of the health education ministry, to Ricka, who facilitated, and to Dr. Swartzberg as he continues to inform and enlighten us and empower us with the information to inspire us to continue to use our common sense approaches to confront this challenge. But nonetheless, God is still in control, but we also have to be mindful and use our intelligence. And I thank God for this ministry. I really, really, really love the health education ministry. You guys are really on point, and we thank God for you. Now, God, now our Lord and Jesus Christ himself, and God, even our Father, which hath loved us, who loves us, and have given us everlasting love and consolation and good hope through grace, comfort us and our hearts, and establish us in every good word and work. To him be glory and majesty, dominion and power, both now and forever. And we all say amen and thank God.
Man, thank you, everybody.
Amen.